This presentation discusses common pitfalls in MRI reporting, their causes, and strategies to avoid them. So, this is very useful for the medical students, radiologists, and the residents. Why MRI pitfalls matter? So, missing a subtle lesion on MRI or overcalling a normal variant can commonly change patient's management. MRI is very powerful tool in diagnosis but also full of the traps. So MRI detects subtle lesion but may lack specificity. So errors can lead to misdiagnosis, unnecessary interventions or missed pathology. First one is the technical pitfalls. So what it include? It includes the artifacts like motion artifact, susceptibility artifact, partial volume averaging, and chemical shift artifact. So technical artifacts are major source of error and understanding them helps in avoiding the misinterpretation and misdiagnosis of the lesion. Now the motion artifact. So what is motion artifact? It is caused by the patient movement, respiration or pulsation and it appear as the blurring or ghosting as we can see here in this image. This is the motion artifact. Here we can see that the blurring of the orbit and paranasal sinus region. Here in this image also we can see this is the motion artifact, multiple images overlapping the main anatomical structure. So this is the ghosting. So we can see in this image the motion artifact is corrected and we can clearly see the brain parenchyma. So this can mimic pathology or obscure pathology. To avoid this, always correlate with other sequences. Susceptibility artifact seen near the metal skull base or air. It can mimic the hemorrhage and it can be differentiated by using the multiple sequences. So differentiating metal from the calcium is achieved by using the phase image as both appear as hypointense or dark in susceptibility image and it shows reversal of signal intensity in phase image. So in this image we can see that the dark blooming or susceptibility artifact in distal femur as well as in the brain. Now next image we can see here there is a dark blooming in brain seen in magnitude image, MIP as well as in susceptibility image. So in all three sequences we can see that this lesion appears dark or blooming whereas in this phase image it shows the reversal of signal intensity that is bright. This is due to the calcium deposition in brain. So this differentiate the blood from calcium deposition and this is confirmed by taking the CT scan image. This is the lesion showing the calcium deposition or calcification in the lesion in left parietal lobe. Now next is the partial volume effect or averaging. So this will caused by the averaging of tissue and this will lead to the missing lesion. So it occurs when multiple tissue occupy one box cell or very thick slices are taken and it is corrected by taking thin slices as we can see here. In this image we can see in first image there is a thick slice image showing partial volume averaging. We cannot see properly knobs and the scar within the this CP angle and CSF spaces. So this is the area and this is the area. Whereas when it is taken in 1 mm slice thickness, we can see that this is the knob anatomy and this is the scar within the CSF space. Chemical shift artifact is important in abdomen imaging and it is seen at the fat water interface. And this can mimic the solid organ invasion in abdomen and this can also mimic as a false lesion or misinterpreted as a abnormal structure. As we can see in this image there is a thin line around the liver as well as in around the liver. This is the diaphragm and this is the bowel loops. So this can mimic as the capsular invasion or solid organ invasion by a lesion and it can also misinterpreted as the missing structure. we can see as this arrow denote the misplacement of the optic knob can be misinterpreted due to the chemical shift artifact. To know more about the MRI artifacts, watch full video on top 10 MRI artifacts and AI resolutions. Link is given in description box. Normal anatomical variants. These are considered in MRI pitfalls because sometimes normal anatomical variant can also be misinterpreted as the pathology, like perivascular spaces, accessory structures. So in this image, we can see that these are the T2 hyperintense lesions. So these are the perivascular spaces. So sometimes they can be misinterpreted as the pathology. Now the accessory muscle like soleus accessorius. So this appear as a soft tissue mass in the posterior medial ankle or within the Kager's fat pad. So this appear as a mass within the Kager's fat pad, and this will lead to the obliteration of Kager's fat pad. We can see here this is the soleus accessorius, and this will lead to the obliteration of Kager's fat pad. This is also denoted by this yellow arrow. So this is the soleus accessorius. So these are the normal anatomical variant that can be considered as the or misinterpreted as the pathology. Normal anatomical variant is also considered in the MRI pitfalls. Sometimes age-related brain changes like atrophy and degenerations can be also considered as the pathology. So this should be considered as the normal anatomical change, not as a pathology. Here we can see in this image both ventricular system as well as the cortical sulci are dilated in bilateral cerebral hemisphere, and these all are symmetrically dilated. So this is due to the age-related changes. Now the interpretation pitfall. It is a very important pitfall because MRI must be interpreted using multi-parametric approach and also the clinical correlation. So single sequence can lead to the increase the risk of diagnostic error due to the limitation of capturing only one type of tissue contrast. So mischaracterization of lesion can be done by using only one sequence. In this image we can see that this is a prostate imaging. So in this image we can see that this is a pyrad 4 lesion. Here we can see a lesion in left peripheral zone. This is the T2 axial image. These are the T2. This is the axial and this is the coronal image. So there is a small nodular lesion, and this is the DWI image showing a high signal intensity lesion, and this is the ADC where we can see that there is a diffusion restriction, and this is the dynamic contrast image. We can see there is a enhancement of the lesion. By seeing these all images we can say that this is the pyrad 4 lesion. So for the characterization and classification of the lesion, all these sequences are required. So ignoring these sequences can lead to the misdiagnosis or underdiagnosis or overdiagnosis of the lesion, and this will affect the management of the patient. And also clinical data is very important for the image interpretation. DWI pitfalls. So always correlate DWI image with ADC map to confirm true diffusion restriction, because if we see high signal intensity in DWI image as we can see here in, and this is the ADC map and this is the T2 image. So if we see high signal intensity or bright image in all three, that is the especially DWI and ADC, then it is called the T2 sign through. And if it is bright in DWI and dark in ADC, then it is called true diffusion restriction. So in this image we can see that this is the T2 sign through, not the true diffusion restriction. Another one is the post-contrast pitfalls. Contrast enhancement is not always the neoplastic lesion or metastatic lesion. So inflammation, infection and neoplastic lesion, all three shows the enhancement. So assess pattern of enhancement, and clinical history is also very important for the diagnosis. And also correlate with the other MRI sequences including the DWI and MRS. So we can see here in this image, the first one is this is the T2 image showing the high signal intensity lesion with peripheral low signal intensity rim. So both lesion appear similar and there is also surrounding edema. First image shows more edema as compared to the second one. This is the contrast image. So both shows the peripheral enhancement. And as we go in DWI image, there is a bright signal in upper image and there is a low signal in lower image. So first one, upper image shows the diffusion restriction in the center of lesion, whereas the second image do not show any diffusion restriction. So cerebral abscess shows the diffusion restriction in the central core, whereas the diffusion restriction not seen in the metastasis of the brain. Reporting pitfalls. Lack of structure in the reporting format. So clear structure reporting improves communication and reduces the error. Another one is the ambiguous language. So use of ambiguous word and the phrases can lead to the diagnostic dilemma and difficult to understand. Like excessive hazing, like suggestive of, suspicious for, compatible with, consistent with, possible and cannot be excluded. Whereas the another one is the comparison ambiguity. So interval change or direct comparison without specific detail of new lesion, resolved lesion or worsening can confuse the clinical picture. So these words like new lesions, resolved or not or worsened, if included in the comparative reporting, then this will more clarify the findings than the only saying that the interval change or direct comparison. How to avoid pitfalls? So first is the checklist approach. So what it includes? Patient and technical factors like confirm patient identity, age and clinical history. Check indication and match the protocol. Review for the artifacts, metal, substance and fat suppression if it is poor or adequate. Ensure correct sequence orientation and coverage and look for missing sequences. Now another one is the clinical correlation. So correlate with the patient's symptom and complaints and the MRI done. Another one is the review all sequences. So as I said, the all sequences are required for the diagnosis of the lesion or characterization and to reach the appropriate diagnosis. All these 3 points are required to avoid the MRI pitfalls. To get more such video, like, share and subscribe my channel. Thank you for watching.